Chapter 51 deals mostly with diarrhea and constipation. So diarrhea is the rapid passing of stools, either lots of frequency, lots of fluid, lots of bulk or weight, or lots of water in the stools. And then constipation would be, like the unable to pass stools or dry, hard stools. This is just a nice breakdown of the anatomy and physiology of your GI tract. And this is on 834 in your textbook, your digestive system. And it talks about the different pieces and parts that are in your digestive system. So acute diarrhea is when you have sudden onset. It can last anywhere from 3 days to 2 weeks. It's usually self-limiting, and it resolves without any long-term complications. Chronic diarrhea is when it lasts more than 3 to 4 weeks, and a lot of times they have fever, loss of appetite, nausea, vomiting, weight loss, and chronic weakness. So it's good to kind of differentiate between the two before you start with treatment, right? Because we don't want to treat somebody who is sick with an anti-diarrheal. So causes of acute diarrhea could be infection, drug-induced, nutritional, or like a protozoa. And then chronic could be some sort of GI issue, diabetes, Addison's disease, thyroid problem, IBS, or HIV. So the goals of diarrhea treatment obviously are to stop the frequency. Fluid and electrolyte balance is important as well. Weight loss, nutritional deficits, that's important as well. If they're having pain, that's important as well. And then skin integrity I would also add on to there, right? Because if the person's having frequent diarrhea, chances are that they're also having skin irritation and or breakdown. So there's a couple different types of drugs that we use to treat diarrhea. There's adsorbents, and those are drugs that kind of bind to things to slow things down. There's anti-motility drugs, like our anticholinergics and our opiates that decrease peristalsis, and then our probiotics that help replace the good bacteria within the gut. So our adsorbents coat the walls of the GI tract. They bind to whatever the bacteria, toxin, or whatever is in there, and then that's eliminated through the stool. So things like this are bismuth, our Pepto-Bismol, activated charcoal, aluminum, and there are some others in there as well. Cholestyramine is one, and polycarbophyll is another. But Pepto-Bismol is, like the drug of choice if you're traveling and you want to avoid traveler's diarrhea, because it's an adsorbent. It will bind and help kill the bacteria that's in the stomach, the bad bacteria, and get rid of it. Anti-motility drugs then, so our anticholinergic, and remember our cholinergics are our wet, wet, wet. There's something leaking out of everything. So our cholinergics are our dry, 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 and nothing's moving at all. So that means that the person has a decrease in intestinal muscle tone and peristalsis, and everything is slowed down. And an example of that would be atropine, hyoscyamine, and then our belladonna alkaloids. And then we have our opiates, right? So these decrease bowel motility because of the narcotic binding effect in the GI tract, and they also reduce pain. They decrease transit time through the bowel, allowing for more time for water and electrolytes to be absorbed. I actually think that should say it increases transit time through the bowel. Examples are a paregoric, tincture of opium, codeine, loperamide, which is actually available over the counter, and then diphenoxylate. Those are all opioids or opiates. And then we have our probiotics, and so you guys give a ton of this. You give acidophilus and lactobacillus and The goal is to promote recolonization of the good flora within the intestinal tract, and hopefully that will suppress the overgrowth of the bad flora. So Lomotil contains diphenoxylate, which is a synthetic opiate agonist, and atropine, an anticholinergic. So why would we give atropine and the opiate agonist at the same time? All right, some adverse effects of our antidiarrheals. There's not many, but they would be, they can impair your bleeding time if you're on Coumadin or warfarin. They can cause constipation and dark stools, especially our Pepto causes dark stools. And the person can experience confusion, ringing in the ears, a metallic taste in the mouth, and even a blue tongue, which is pretty interesting. Okay. And those are listed on 831 at the bottom in table 51-2. And they actually list Pepto as giving you blue gums rather than a blue tongue. Anticholinergics, so remember, can't, what did you say? Can't pee, can't see, can't spit, can't poop. So anticholinergics cause urinary retention, problems with getting an erection, headaches, dizziness, confusion, anxiety, drowsiness, confusion again, so they must have been confused when they created the slide, dry skin, flushing, blurred vision, hypotension, and bradycardia. On a good bad scale, all bad. And then the opiates, very similar, except they can cause the pinpoint pupils, the respiratory depression, but still the same: drowsiness, dizziness, lethargy, nausea, vomiting, constipation, hypotension, urinary retention as well, and then flushing. Adsorbents, so they're binding to things in the stomach or in the intestines, can also bind to other drugs, right? And then they can increase bleeding time when given with anticoagulants like warfarin. And the methotrexate can become toxic when given with adsorbents. So even though it's an over-the-counter medicine, people really should check with their doctor if they're on serious medications before they take any of these. Things you should consider: obtain a history, right? And so always be thinking, do I think this is infectious, or do I think that this is, related to diet? Trying to figure out what the cause is. Don't give bismuth subsalicylate. Remember, salicylic acid is aspirin. Don't give subsalicylate to children or teenagers with chickenpox or influenza, because aspirin is not good when kids have a viral illness, because it can cause Rye syndrome, right? So if they have some diarrhea along with their fever and their viral illness, they should not get Pepto-Bismol. Before administering belladonna alkaloids, right, we talked about that being an anticholinergic, it is most important for the nurse to assess the patient for a history of which condition. So these cause things such as urinary retention, impotence, headache, dizziness, anxiety, drowsiness, bradycardia, hypotension, dry skin, flushing, and blurred vision. So what would we assess somebody for? And there's more information about belladonna alkaloid specifically on 831. So use these carefully in patients, elderly patients. Don't administer anticholinergics to patients with a history of narrow angle glaucoma, GI obstruction, myasthenia gravis, paralytic ileus, or toxic megacolon. Okay, these will make these conditions worse. Teach the patient to take the meds exactly as prescribed. and watch their INO, watch their electrolytes, things like that. Teach the patients to notify their prescriber immediately if their symptoms persist or if they get things like fever, severe pain, bloody diarrhea, anything like that. And then always watch for the therapeutic effect, and the therapeutic effect would be that they are no longer having diarrhea. Which antidiarrheal does the nurse associate with the development of adverse effects of urinary retention, headache, confusion, dry skin, rash, and blurred vision? What do you think? I think we can rule out 2, and then you're going to have to probably look to see which one of the other 2 it is. Constipation, abnormally infrequent and difficult passage of feces through the lower GI tract. Okay, it's a symptom of some other problem. It's not a disease. And then we often treat it with our laxatives, right? So some things that are important to know. The usual time between when you eat something and when you exit something is between 24 to 36 hours. Laxatives themselves are the most misused over-the-counter medications. With the exception of bulk-forming laxatives, laxatives are not to be used for long periods of time. Okay. Only bulk-forming laxatives are safe for use long-term. These are our high-fiber ones. They absorb water to increase bulk. Okay, they distend the bowel and initiate reflex bowel activity. So all they are doing is increasing bulk within the intestines, which initiates normal reflexes. So that's like our psyllium stuff, our Metamucil, and then our Citracel. Okay, so the way that these work is just to increase water in the GI tract. So obviously then they have to be taken with water. Our emollients then are stool softeners and our lubricants, and these put more water and fat into the stools, right? So that's our colace and our mineral oils. It lubricates the fecal material in the intestinal walls, helps things to move out more easily. We have hyperosmotic laxatives, which increase how much water is in the fecal material itself, and then that causes bowel distension, which puts pressure on the walls of the bowels, which speeds up peristalsis and evacuation. So that's our PEG, our polyethylene glycol, so our Miralax, right? Things with sorbitol in them tend to, especially larger things, larger doses of sorbitol, I should say, are laxatives, and that's why we mix sorbitol in with charcoal. So we don't just give activated charcoal for an overdose, we give activated charcoal with sorbitol. So charcoal is an adsorbent. It will bind to whatever chemical the person swallowed, and then the sorbitol will rush it through your system to decrease the ability of you to absorb it into your body. Glycerin is another one, and then lactulose. And lactulose is very unique in the fact that lactulose specifically is used to decrease serum ammonia levels. And then there's saline laxatives. So these increase the pressure within the intestinal tract, and that increases peristalsis as well and makes you go faster. So this would be things like milk of magnesia and citrate. And I know that sounds funny that we're giving magnesium and it's a saline laxative, but it truly is. Then we have stimulant laxatives. So we have Senokot and Bisacodyl, which is Dulcolax, and both of those increase peristalsis. So there's nerve stimulation, right? And these both can cause some dehydration as well, so just be careful with these stimulants. And then we have opiate antagonists. So these Relistor and Entereg are used, they're pretty new, but they're used specifically for people who are on chronic opiates or who've had bowel resection therapy, and they basically allow the person to have normal bowel movements in theory, but we've seen some of these people in clinical even here who've been admitted because of severe side effects of severe abdominal pain and then diarrhea associated with these. Okay, so you can read through the indications. These are on 835, table 51-6. And 51-7, the indications and the adverse effects. So you're receiving lactulose 4 times a day, or your patient is, but they do not have a history of constipation. In fact, he has had bowel movements every day. What is the probable reason for the lactulose? Why do we give lactulose? As a matter of fact, you will most likely never give it for constipation. You can give it orally, or you can even give it rectally, which is one of the coolest things about lactulose, is it comes in a rectal prep. All right, so bulk forming laxatives. So one of the things you do need to know, they can cause impaction if they're not taken with enough fluid, right? So people who take a lot of fiber need a lot of water, but then also they can cause fluid overload, so you have to kind of balance it as well. And if it causes diarrhea, then you can get electrolyte imbalances. And if they don't take it with enough water initially, it can also cause esophageal blockages, which is kind of bad. So the bulk forming laxatives are the ones that we should use the most. They're non-habit forming. They're the only ones that are safe for long term, but they really have to be taken with adequate amounts of water, and you need to monitor the patient. Okay. The rest of these you can read through. The saline ones, these are the ones that are going to give you the most cramping and explosive diarrhea, the MAG, because they really just get things moving. And then the stimulant ones are going to give you gastric pain, increased peristalsis, and they can also give you some dehydration. So all laxatives have the potential to cause electrolyte imbalances, and that's important. So what's important for us is that we want to obtain a good history, look at fluid and electrolytes before initiating therapy to make sure we know where they're at as far as their acid base, as far as their electrolyte balance, and as far as their fluid balance. People should not take laxatives or cathartic drugs if they have nausea, vomiting, or abdominal pain initially, unless you think they're just a little uncomfortable, like from constipation. But the problem could be that they're obstructed, and then you start putting other drugs in there, and you just make the obstruction even worse. So other things that you should teach people is that, hey, yeah, something like, psyllium may be great as a daily laxative, but even better would be a high fiber diet, like healthy fruits and vegetables, where you're not just filling yourself full of, corn husk or whatever. So long-term use of laxatives often results in decreased bowel tone and leads to dependency. So you actually become dependent on the laxatives, can't go without them. The tablets themselves should always be swallowed whole, not crushed or chewed, especially if they're enteric coated. Take all laxatives with 6 to 8 ounces of water. The bulk forming laxatives is directed with at least 8 ounces of water. Okay. Bisacodyl has to go with water because it can't go with milk and acids or juices. Patients should call their doctor then if they're having any problems at all. And the therapeutic effect then of the laxative is that they're going to stop having constipation. A 48-year-old patient has been admitted with abdominal pain and states that she has not had a bowel movement in 4 days. Her abdomen is distended and slightly tender. Which laxative would be appropriate for this patient? Let you think on that one. Irritable bowel syndrome. Okay, so the person has chronic intestinal discomfort, and they usually take over-the-counter laxatives and or anti-diarrheal drugs to treat their back and forth between the diarrhea and the constipation. There are a couple drugs on the market, Zelnorm, Amitiza, and Lotronex, that people can take that are supposed to help with the constipation, chronic idiopathic constipation, and the Lotronex helps with the diarrhea. So the first two help with constipation, and the Lotronex helps with the diarrhea. So again, they're kind of new. There's not a lot of information in your book about them, but just basically follow the administration guidelines. If you're giving a new drug, you want to look them up before you give them so that you're 100% sure of what you're giving. And the last thing I want to mention is polyethylene glycol. So the PEG Lights, the Miralax that we give, also comes in another prep, and it's called polyethylene glycol 3350. It's on page 838 in your textbook. PEG 3350 is the Go Lightly, the Colite, the movie prep, the Half Lightly, however you mix it. That's the surgical prep. So if somebody's going to be having like a colonoscopy or something, that is what they might be taking, okay? And different doctors are going to use different preps, but if you hear somebody talking about Go Lightly, it's polyethylene glycol, but it's just a more potent form than the Miralax, okay? So it's commonly given before diagnostic or surgical bowel procedures because it's very potent laxative that induces total cleansing of the bowel. It's usually given in a powdered form, and then the person reconstitutes it according to the instructions. And then the person drinks it, and within 30 to 60 minutes, they have complete evacuation and cleansing of the bowel, onset within 30 to 60 minutes, and done within 4 hours. So that's just something to keep in mind when somebody talks to you about Go Lightly. It's not like they just got a dose of Miralax. It's like they took, like, you know, a monster bottle of Miralax all at the same time. All right, so that is chapter 51.